Chapter 15, the Endocrine System. The endocrinology system is composed of glands that, in particular, we're concerned with pituitary, hypothalamus, thyroid, and the adrenal gland. Endocrinology disorders can be classified into two categories. A primary disorder is involved directly with an issue within the gland or the organ. If another area is causing problems for the gland or organ, it becomes a secondary disorder, and this is important in our testing diagnosis. The endocrine system is a group of ductless glands that secrete hormones into our bloodstream. Upon it. They are based upon structure. There are steroids, polypeptides, or amines, of which we recognize these terminology from protein and lipids. A steroid is obviously insoluble in water. It does bind reversibly to a carrier, and the free form is what is active. The polypeptides are water soluble. They do have a short half-life, and the amines are water soluble. The methodology that we use in testing depends upon their structure. Also, how we are concerned with our collection is depend on if it's a diurnal or circadian rhythmic method produced within the body. And we're concerned with low normal versus low pathological, hence our high sensitivity testing. These are structures of those three categories: the steroids, the amines, and the polypeptides. This chart is in your textbook listing the hormones that would fall into these categories. We have a whole lot more polypeptides than we are interested in the amino acids or the steroids. Hormones have a feedback mechanism to help maintain a steady state of this hormone. The level of one may trigger a gland to turn off or on the production of another one. We have a negative feedback. Most loops are driven by this method. Low level stimulates production of the other. A few of them do have a positive feedback. It's basically a checks and balance system. We do immunoassay for most of our hormone measurement, and you've already learned about competitive binding, where that concentration is inversely proportional to the complex we're interested in, and basic immunometric methodologies consisting of our sandwich method, where the concentration is directly proportional to this complex. The pituitary gland consists of a front and a back, anterior and posterior, and different hormones are produced in the sections. In the anterior pituitary, we're interested in growth hormone, ACTH, TSH. In the posterior pituitary, we are going to discuss antidiuretic hormone and oxytocin. This table shows you the pituitary hormones, where they come from, their target tissues, and what they will actually be doing. Growth hormone obviously promotes growth. It causes changes in your electrolyte metabolism. It causes uptake of fatty acids by your muscles. It accelerates the fat from your adipose tissue, and it will cause a decrease in blood glucose. Obviously, growth hormone would be higher in your adolescents and children. When it is elevated, it could be due to adenomas in the pituitary gland, or it could be decreased from a congenital or acquired condition, and it will cause growth retardation. This is significant in children, and you've probably heard of some children having growth hormone injections during a short period of their time to promote their growth. Prolactin is initiated and produced during lactation. It will control water, osmolality, fat and carbohydrate metabolism, along with calcium and vitamin D for our bones. It acts upon fetal lung development during pregnancy. Elevation can decrease prolactin is not significant. Okay, going back to the posterior pituitary antidiuretic hormone, we will continue to talk about this as we did with our renal introduction, and again this next semester with our urinalysis. It's also called vasopressin. It is a peptide, and it has a major role in water homeostasis. Diabetic insipidus, they have a deficiency, they have huge urine outputs and constant thirst. And we bring up this again, the syndrome of inappropriate ADH secretion, where it's being produced all the time, can't shut it off. Oxytocin is a stimulator of the uterus for birth. It's also used as a therapeutic agent to induce lactation. Here's your adrenal gland. It is a little cap that sits on top of your kidneys, and it has an interior and an exterior area. The exterior, the cortex, is much larger than the interior. In this adrenal gland cross section, you can see here's your cortex, big area, and then a much smaller section is your medulla. In this smaller section inside the medulla, we produce catecholamines. Epinephrine is one that you've probably heard in the past. There's dopamine and norepinephrine. And their metabolism include the three listed below that we may or may not be testing. But there's a lot of catecholamine production from this small area. We're going to have tumors that will affect catecholamine production. A pheochromocytoma, these are tumors within the cell tissue, and there are neuroblastomas that are more common in pediatric patients. On the outer portion of the adrenal gland, we secrete glucocorticoids. Cortisol is the primary one that we know about. It has a role in your carb and lipid production. It promotes gluconeogenesis. So recall what gluconeogenesis is. They also produce mineralocorticoids, which are the aldosterone, having to do with sodium retention in the renal system, and our renin-angiotensinogen system, the RAS that we covered under electrolytes. This cortex also produces the androgens. ACTH, or adrenal corticotropic hormone, is produced from ACTH, and it transports cholesterol. It is regulated by cortisol. We will see a diurnal variation, so it would be time dependent. Normally we measure cortisol levels at 8 o'clock in the morning. It is declining, and we should see the low reduction at midnight. So often you will collect first morning and midnight specimens. timing would be most significant. With adrenal hypofunction, either primary or secondary, Addison's disease is one where we have an elevated ACTH, and you will see hyperfunction. With Cushing's disease, we can stimulate hyperfunction with a dexamethasone test, and we will measure plasma and urine cortisol levels. With hyperplasia, you might see some enzyme defects. Here is the feedback mechanism that you're going to see with the glands and the hormones production. Here we have the adrenal gland on top of the kidneys. The ACTH is coming from the pituitary, acting upon the adrenal gland, producing cortisol, which will go up to the hypothalamus and tell it cortisol releasing hormone goes to the pituitary. Stress is a big trigger for this mechanism, and so often we see a change in our body systems when we are under stress. Addison's disease is a primary hypoadrenalism. We measure cortisol and ACTH levels. The ACTH can be stimulated by injecting a cortisol. This is usually done by a physician or an inpatient in the room. Lab may or may not be involved in that. We will draw timed cortisol. We need a baseline, and then we will inject the cortisol and collect at 30 minutes and 60 minutes. Okay, normally this is going to simulate ACTH production. So we're going to see a cortisol rise. If we see a low baseline with no response on the 30 and 60, then we consider it primary hypothyroidism. Cushing syndrome is an adrenal hyperfunction. We will see increased production of glucocorticoid and cortisol. It occurs with tumors and cancers. If it's in the pituitary gland, we have excess ACTH. If it's in the adrenal gland, it would be decreased. Okay, our androids. Reproductive system, we have testosterone, estrogen, progesterone, FSH, and LH. I'm not going to get into a lot of specifics about these. Next is the thyroid gland. And this is one of the key tests that we perform in the laboratory with our immunoassays. Thyroid is a very small organ in the throat consisting of two lobes. The parathyroid is in with them. They have secretory units, and they are composed of a colloid amorphous material and the amino acid tyrosine. The thyroid hormones are T4 and T3, and they are transported throughout the circulatory system by thyroxine binding globulin and our prealbumin we learned about, and albumin. The functioning tests that we perform in the laboratory are TSH, thyroid stimulating hormone, our total T4, thyroxine, our total T3, triiodothyronine, thyroid releasing hormones, reverse T3, and thyroglobulin antibody. T3 and T4 free are the functional thyroid hormones. And as you can see, they're just a very minute amount, but they are extremely significant. T4, tetraiodothyronine, hence the 4. Most of it is bound. It is useful measurement for hyperthyroidism, primary and secondary hypothyroidism, and monitoring our TSH suppression therapy. That's where we want to reduce production. T3, which is a triiodothyronine, T3 is primarily responsible for the effects of the thyroid hormone on organs. The major biologically active hormone, and remember that would be the free portion. We use it for the diagnosis of hyperthyroidism and detection. TSH is not a thyroid hormone. It is thyroid stimulating hormone. It's produced in the anterior pituitary. It is a glycoprotein, and we use it for initial diagnosis of thyroid dysfunction. Very slight changes can produce a big change in TSH. And it's going to be opposite. Remember, it's a negative feedback system. TSH testing is very sensitive. We are on, generation 4 or 5, and it's an excellent test method for analyzing TSH. Reference intervals. For an adult, we're looking at from 0.5 to 5, and notice that a neonate is much higher. We do measure thyroids on our newborn screens. Your textbook talks about the different testing, and when we first started, generally we use TSH as a screening, and then we follow up with free T4s or free T3 testing. And they should be the opposite if we're having a problem. Hypothyroidism, if the damage is on the thyroid gland. As opposed to secondary, where it could be the pituitary causing TSH level interruption. Hyperthyroidism is dependent on your TSH. If we have goiter on the thyroid, Graves' disease, or nodules. TSH levels in your diseases. You will have increased TSH when you have primary hypothyroidism. Hashimoto's is a thyroid condition. Although a good portion of hypothyroid patients have no symptoms, no function. You will see decreased TSH levels in primary hyperthyroidism. Remember, they're feedback, so they work opposite of each other. Free T3 and T4 in diseases. If your thyroid binding proteins are normal, usually then your free T3 correlates with your total, obviously. But if you're having a problem with these proteins, seeing a change in it, then the free portions are more significant. Thyroid binding globulin in disease. Okay, this chart is showing you when you're having increases, I, and decreases, or undetectable, or not applicable, or normal. Okay, in primary hypothyroidism, that means our T3, let's go to the free portion, and free T4 will be decreased. The thyroid is not functioning, it's not producing the hormones, but the TSH is coming from the pituitary gland trying to tell the thyroid to function, so it keeps pumping out its hormone and it will be elevated. Hypothyroidism. So our T4s and T3s are all decreased, hypo. If it's primary, it means the TSH will be elevated. If it's secondary, which would be like your pituitary isn't working, it's not going to make TSH, and that's the problem. It's no good to fix the thyroid gland because it's able to produce, but it hasn't been told to produce. Hyperthyroidism, they are all increased, and if it is primary, the TSH will be decreased. Because these are increased, there's not that feedback mechanism. But if it's secondary, then we will see an increased TSH. This chart should help you with your primary and secondary hyper and hypothyroidism, and a listed conditions, names of diseases. Primary, you're going to see decreased in your thyroid glands for hypo. Primary in your hyper, you're going to see elevated, and TSH will be just the opposite. When it's secondary, hypo is decreased. The secondary will also be decreased, possibly normal. And in hyper, they're all elevated, and your secondary is elevated also, because we're not having that feedback mechanism to turn it off.